Very good evening, guys. How are you? How is your preparation going on? So we are going to do recall of the MCQs in this session. Very good evening, Anurag. Very good evening, Pooja. So we are going to do recall of the FMG questions in this session. So I have collected the FMG recall June 2021 questions. So first we will see all the 2021 questions followed by the next paper. So am I audible to you people? Right. So myself, I am Dr. Ramyasree of Gyn Guru. So here we are going to discuss the MCQs of Obstetrics and Gynecology, which are recalls. So recall is very important because you tend to get so many questions again and again from the recalls. So you have to be perfect with the recall. So how is your preparation going on, guys? So we'll start with the first question. I will first read the question, you try to answer, and then we will understand the answer. Okay? So a couple presented with infertility. Semen analysis is normal. The female had menorrhagia. So menorrhagia is heavy menstrual bleeding. On HSG, there is distal dilatation of fimbria. What is the likely cause? Tubal polyp, tubal endometriosis, tubal spasm, tubal salpingitis. So this is a wonderful question actually. So it is on infertility. So infertility भी एक बहुत important topic है for your while your preparation, right? So यहाँ पे So there is no male factor infertility यहाँ पे क्योंकि semen analysis normal है. एक ही clue, one clue which they have given us for this question is female is having menorrhagia. So menorrhagia is heavy menstrual bleeding. And another clue which they have given us is that there is distal dilatation of the fimbria. So the tubes are dilated. So probably there can be a pus inside or whatever might be the reason, there is a dilatation of the tubes. So tubal polyp, there can be dilatation but they are not associated with menorrhagia क्योंकि tubal polyp तो tube के अंदर होगा. Tubal endometriosis is pretty rare. Again, tubal endometriosis won't cause distal dilatation of fimbria. Tubal spasm, now this can't be tubal spasm also. Because tubal spasm is nothing associated with menorrhagia. So the two clues which they gave us in this question, there is distal dilatation of fimbria and associated with menorrhagia. So along with dilatation of fimbria. So dilatation of fimbria, one thing which is striking my brain is probably this is an infection. So it is going more in favor of tubal salpingitis. Now next thing which is actually again going towards the salpingitis is whenever we have PID, pelvic inflammatory disease. So salpingitis will be associated with some amount of endometritis. So pelvic inflammatory disease say the endometrium will be in inflammation and that inflammation will lead to increased vascularity of the endometrium and it will lead to heavy menstrual bleeding. So her heavy menstrual bleeding and distal dilatation of fimbria both are matching towards your diagnosis of tubal salpingitis. So here the answer is tubal salpingitis. Okay, I think all this time I was not able to see any of your answers, but now I am able to see your answers. Thank you, Priya. So I'm happy many of you have answered D, but some of you have answered B also. So B, why B is not the answer? Understand that point also. Tubal endometriosis may you will not see distal dilatation of fimbria. First and foremost, tubal endometriosis is pretty rare. And tubal endometriosis mein you will not see distal dilatation of fimbria. So here distal dilatation of fimbria is more in favor of tubal salpingitis. So इसीलिए answer is D. So now I'll ask you some single liners. Try to answer for that. सबसे पहला question. What is the most common cause of salpingitis? Most common organism. What is the most common organism causing salpingitis? Yes, Amrita, Mohit, Pooja, Sunny. So PID or pelvic inflammatory disease is inflammation and infection of the upper genital tract. So it includes salpingitis, oophoritis, endometritis, only and parametritis. But it does not include cervicitis and vaginitis. Right? Very good, Abhishek. Excellent. So most common organism causing salpingitis is Chlamydia trachomatis, D2K. Chlamydia trachomatis D2K. So most common organism causing salpingitis is Chlamydia trachomatis D2K, right? And second most common organism causing salpingitis is gonococci. And which is the organism which is associated with distal dilatation of fimbria? So distal tubal block or distal dilatation of fimbria is more commonly seen with gonococci. And most common organism causing salpingitis in a virgin female is tuberculosis. In unmarried girl or in a virgin female is tuberculosis. So these are some important points you should know. Now the take home message यहाँ पे है, HSG image has been asked many times as an MCQ. So dilatation of tubes on HSG is nothing but salpingitis, tubal salpingitis. Okay. And the most common site of PID is also salpingitis itself. What is the most common site of endometriosis? Most common site of endometriosis. Right. So the most common site of endometriosis is ovary. Ovary is the most common site, then tube, right? Okay, let's go to the next question. Women with a history of previous cesarean section. Women with a history of previous cesarean section presented with prolonged labor. Patient is hypotensive. Fetal heart rate is not audible. Fetal parts are easily palpable on examination. What is the diagnosis? Again, a very good clinical scenario you are seeing here. Now, guys, one more point. It's okay even if you answer wrong. Keep attempting. That's the most important. So do an active participation in this session. That it will be a quick brush up of all your obstetrics and gynecology in this session. So answer correct or wrong doesn't matter. Keep answering. Okay. Right. Let us see each option ke hisab se. Now, one thing is pretty clear. Fetal heart rate is not audible means bacha is already dead. Fetal heart rate is not audible. Bacha is already dead. Okay, I see some of you answering polyhydramnios. I see some of you answering polyhydramnios. Now my question to you is, what is polyhydramnios? Polyhydramnios is excess accumulation of fluid in the abdomen. Polyhydramnios is excess accumulation of the fluid in the abdomen. So when amniotic fluid index, amniotic fluid index is more than 25 centimeters, you call it as polyhydramnios. Now polyhydramnios में abdomen is too much over distended. I'll ask you one question guys. मानो एक ओवर डिस्टेंडेड बैलून है और उसके अंदर एक बॉल है, तो ball is inside and over distended balloon filled with water is outside. Can you feel the ball easily when you have an over distended balloon with water outside the ball? No, you can't feel it easily. So polyhydramnios में fetal parts are not easily palpable. Polyhydramnios में fetal heart rate is not audible. I 100% agree. As I told you, it's an over distended balloon and you have bacha inside that. So heart rate to not easily heard. But fetal parts are also not easily palpable. Okay. This looks in favor of fetal intrauterine death, but I would like to choose for a more better answer. Now there are two options which are doing tug of war for this answer. In abruption, so abruption is premature separation of a normally situated placenta. Abruption is premature separation of normally situated placenta. See, what you want to understand is how should be your approach to a question in the exam. Premature separation of normally situated placenta. So you have to understand how should be your approach in your exam, right? So uterine rupture is where all layers of the uterus are disrupted. That is endometrium, myometrium and serosa. Now my question to you is, in which you will have easy palpability of bacha? In abruption या uterine rupture? Abruption mein uterus is continuously contracting. So when uterus is continuously contracting, you can't feel the baby. Uterine rupture mein uterus is disrupted. So baby is out. So as the uterus is disrupted and the baby is out, in uterine rupture, fetus is easily palpable. Next, hypotension can be there in both abruption and uterine rupture because of the hemoperitoneum. Previous cesarean section favors uterine rupture more compared to abruption. Previous cesarean section favors uterine rupture. One of the complication of previous cesarean section is uterine rupture. So as this is a case of previous cesarean section, my answer will go in favor of uterine rupture than abruption. So this is your last exam ka paper. So nowadays they are asking you more clinical questions. They want you to understand the patient, understand the clinical scenario and then answer. Now what are the points in favor of uterine rupture यहाँ पे? Previous cesarean section का one of the risk factor है rupture. Patient hypotensive, so patient is in shock. Fetal parts are easily palpable are also seen in the rupture. So now we will discuss what all clinical picture or clinical findings you see with rupture. So all of you are convinced that answer should be rupture. Any doubts? So I hope all of you are convinced that answer should be rupture. Okay. Next, clinical picture of rupture is, so patient will be in shock, hypotensive and tachycardia, fetal distress to fetal death, So if you have done delay, obviously fetal death. Can you feel the uterine contour in rupture? No. So uterine contour is lost. Uterine contour is lost. Uterine contour is lost. Fetal parts are easily palpable. Per vaginum, you will have bleeding per vaginum. Bleeding per vaginum. And there will be loss of station. Loss of station of fetal head. What do I mean by last statement? Oh, I'll explain you. Mano, abhi tak, till now when I was doing PV, I was feeling the baby is at +2 station. When I was doing PV all this time, I was feeling the baby's head is at +2 station. But once there is a rupture and baby has come out of the uterus, you will not feel the baby's head. So that is the loss of station. Baby's head has gone up somewhere, so loss of the station. Okay. Abhishek, you're asking me about the CTG. No worries, I'll try to post some questions on CTGs and teach the CTG. Okay. Next question. A para 2 living to postpartum female. So in the previous question, answer is B. In the previous question, the answer is B. So it is uterine rupture with fetal death. So between C and B, B is the best answer, and I think whether C was answer option there or not, God knows, right? Next question. A para 2 living to postpartum female presents with a few weeks of spotting. After delivery, patient is presenting to you with spotting. History of bleeding per vaginum for 3 months and currently presents with heavy bleeding. She gives previous history of DNC in some other hospital. What could be the reason? Normal lochia, DIC, retained bits of placenta, gestational trophoblastic neoplasia. Again, this is a very tough question, you know. So, she has delivered. So, para 2 living to patient, she has delivered few weeks back. Not few weeks, she has delivered long back. From few days, she is having continuous spotting. And 3 months pehle, there was heavy bleeding. And for that, she has underwent DNC also. And now again, she is presenting to you with spotting. See, 3 months back, when she has underwent DNC, I think all the products would have been removed. So, this is unlikely to be retained placenta again, retained bits again. Because already DNC, dilatation and curettage is being done. So, again, why will she get retained bits? Henna, this is absolutely not normal lochia. Normal lochia or postpartum discharge will be present how long? Very good, excellent, Abhishek and Muttu. Yes, correct. So normal lochia is usually seen only up to normal lochia तो बिल्कुल नहीं हो सकता आंसर क्योंकि normal lochia will be present only first fortnight, first 14 days, right? So I remove this answer. This is not DIC also because suddenly why will she go into DIC? This is not in favor of retained bits of placenta also क्योंकि retained bits of placenta के लिए they've already done DNC. Now, when you have persistence of some bleeding or spotting which starts after 3 months, you should think in terms of gestational trophoblastic neoplasia. You should think in terms of gestational trophoblastic neoplasia, right? So, what is the in gestational trophoblastic neoplasia? You have 4 types of cancers. You have 4 types of cancer: choriocarcinoma, placental site trophoblastic tumor, epithelioid trophoblastic tumor, and invasive mole. Choriocarcinoma, placental site trophoblastic tumor, epithelioid trophoblastic tumor, and invasive mole. Whenever you have persistence of bleeding after delivery, that too lasting beyond 3 months, you should always think in terms of gestational trophoblastic neoplasia. And in sare gestational trophoblastic neoplasia mein, which is the most common? Which is the most common? Choriocarcinoma is the most common. Choriocarcinoma is the most common, right? So this is more in favor of choriocarcinoma. This is more in the favor of choriocarcinoma, right? Next. So again, next very important topic for your exam, जो आप लोग को must to revise before you go to exam is postpartum hemorrhage. Postpartum hemorrhage में सारे drugs, all the drugs, their dosages, their route of giving, maximum dose, complications, side effects should be on your tongue tips. Even if somebody wakes you in the middle of night and asks you that question, you should be able to answer. So PPH, please revise before you go to exam. Okay? Complication associated with IV bolus oxytocin is. Complication associated with IV bolus oxytocin is. So usually oxytocin should be given either IM or IV in drip. We never prefer IV bolus. So we never give IV bolus oxytocin because IV bolus oxytocin can lead to hypotension. IV bolus oxytocin can lead to hypotension. So the answer here is hypotension. IV bolus oxytocin will lead to hypotension. Very soon, Purvang, I will do one more video exclusively for NEETPG PYQs. Okay. Within this next week, I'll do for NEETPG. Okay. Right. In this question, I have Kalki asking me a query. Yes, there should be history of increase. No, you have to confirm that this is GTN. You do beta HCG levels and you will see beta HCG in 40,000, 1 lakh, that much high levels of beta HCG you will see. And when you see so much high levels of beta HCG, that will confirm that it is GTN. So you will not do beta, they will not give you history of increased beta HCG. When you do beta HCG levels, you will find it there more. Okay? So oxytocin का So here, if you first we will tell all the names, no. So first, if I see what is A Which hormone is A, which is only rising in the luteal phase around day 22? So hormone A is serum progesterone. Very good. So just before the around the ovulation, this B which is rising so much is the one which is responsible for ovulation. And what is this B? And what is this B? What is this B? So B is nothing but LH surge. B is nothing but LH surge. So LH surge is mainly responsible for ovulation. LH surge is mainly responsible for ovulation. So the answer here is B. The answer here is B. But we will answer about all entire graph. We will answer about the entire graph. So A is serum progesterone. A is serum progesterone. B is LH surge. C. What is C? So C, if you are seeing, has two peaks. One peak here, one peak afterwards. So C has two peaks. So what is this hormone which has two peaks? One just before ovulation, another peak around day 22. The one hormone which has two peaks is serum estrogen. And D is FSH surge. D is FSH surge. Okay. So among all these hormones, which is the hormone mainly responsible for ovulation? It is the LH surge. So LH surge is mainly responsible for ovulation. But actually at the time of ovulation, you have both LH surge as well as FSH surge. So at the time of ovulation, you'll have both LH surge and FSH surge. Okay. But here what we have is, what they're asking us are precisely regarding the peak which is responsible for ovulation, that is the LH surge. Next question. A 23-year-old primary gravida, presents at 19 weeks of pregnancy for the first time. She has no significant medical history. Her family history is significant for diabetes. Her ECG is normal. Urine analysis is also normal. Her FBS is 126. HbA1c is 6.5. What is the likely diagnosis? What is the likely diagnosis? So here, if you observe, the patient has come to you for the very first time at 19 weeks to the hospital. And it's a straight cut diagnosis, and this has been repeated so many times for both NEET as well as FMGE students, right? So here, very good. This is a pre-gestational diabetes. This is pre-gestational diabetes. So when you have diabetes before pregnancy, you call it as pre-gestational diabetes. So when you have diabetes before pregnancy, you call it as pre-gestational diabetes. You call it as pre-gestational diabetes. So diabetes before pregnancy is called as pre-gestational or overt diabetes. How do we make the diagnosis of pre-gestational diabetes? So diagnosis of pre-gestational diabetes may FBS for these patients will be more than 126 milligram per deciliter. FBS will be more than 126 milligrams. Postprandial blood sugars will be more than 200 milligram per deciliter. And HbA1c will be more than 6.5. So when you see any of these combination, you can directly answer this as option A. Now very important point I'll tell you, which is usually a very common silly mistake which students do. So guys, I want you to conquer the silly mistake syndrome before you finish your exam. So please practice more and more MCQs. Keep practicing. At least daily half an hour though you give for doing some MCQs. Okay. When do you call gestational diabetes? When do you call gestational diabetes? So gestational diabetes is glucose intolerance for the first time in pregnancy. It has nothing to do with 20 weeks. When is that after 20 weeks definition? That after 20 weeks wala definition is for preeclampsia. That has nothing to do with this. After 20 weeks wala definition is for hypertension. Gestational hypertension is the blood pressure more than 140/90 for the first time after 20 weeks. Right? Here you have nothing to do with the 20 weeks at all. Here, when you have glucose intolerance for the first time in pregnancy, you call it as gestational diabetes mellitus any time in pregnancy. Whether in first trimester, second trimester, third trimester, doesn't matter. But if you see glucose intolerance for the first time in pregnancy, you call it as GDM. And if you have glucose intolerance before pregnancy, now these levels tell that she has blood sugars from long back, but we have picked up now. So if there is glucose intolerance before pregnancy, you call it as overt diabetes mellitus. You call it as overt diabetes mellitus. Okay? Understood, Mani, Alia? Did you अभी वो 20 वीक्स का कंफ्यूजन गॉन ना, क्योंकि ये सिली मिस्टेक आप एग्जाम में नहीं करना चाहिए. Okay, next question to you people. Which is associated with congenital malformation? Gestational diabetes या overt diabetes? Which is associated with congenital malformation? Gestational diabetes या overt diabetes? This is none of the criteria which you read, know that ACOG criteria, ADA criteria. This is normal FBS and PPBS levels. Normal by FBS and PPBS also you can diagnose the GDM and overt DM. So overt DM ke liye remember this. FBS will be more than 126, PPBS more than 200 and HbA1c more than 6.5. You call it as overt diabetic mellitus, overt diabetes mellitus. So this has been asked as an MCQ even in NEET also, guys. Okay. So congenital malformations are more seen in overt DM. Overt DM is associated with congenital malformations. Now I'll ask you 3 single liners here. I want all of you to answer those single liners. Which is the most common congenital malformation? Which is the most common congenital malformation on the whole in the overt DM? Which is the most common congenital malformation in the overt DM? Yes, guys, which is the most common congenital malformation in the overt DM? Ventricular septal defect followed by neural tube defects. The most common congenital malformation in overt diabetic patients is ventricular septal defects more than neural tube defects. Next. Most specific. Again, ये बहुत important है. Write down somewhere or memorize this. Most specific malformation. अगर question has come कि which is the most specific congenital malformation? Then your answer is sacral agenesis. Sacral agenesis या caudal regression syndrome. So most specific cardiac anomaly. Most specific cardiac anomaly is very good, Kalki, excellent. Most specific cardiac anomaly is transposition of great arteries. Is transposition of Great arteries. So most specific cardiac anomaly is transposition of great arteries. So these are the 3-4 single liners which you all should know. Let us go to the next question. Yes. This also I actually felt very बहुत अच्छा लगा this question. So what is this instrument? सबसे पहले I want you people to answer what is this instrument. What is this instrument? False statement regarding the following image. False statement regarding the following image. So first and foremost, you should answer what is this instrument. Very good. I see many of you answering correct answer. Excellent. Very good. Your answer is correct. But tell me what is this instrument, no? So it is having a double valve piston. 2 valves of pistons. Double valve piston. This is nothing but manual vacuum aspiration. This is manual vacuum aspiration. In the name itself it is there. In the name itself it is there. Manual vacuum aspiration. So this is manually operated. So you do not require electricity. This is manually operated. So you do not require electricity. That's good money. So this is used for abortion. When you want to remove all the products of conception, we use this manual vacuum aspiration, especially in PHCs and all, where you don't have the setup of anesthesia or electricity and anything. So you can use this manual vacuum aspiration syringe. So in this you don't require any electricity, you don't require any anesthesia. It's an OPD procedure. You don't require dilatation of cervix. To this manual vacuum aspiration syringe, you insert a Carman's cannula. And this syringe with two valves will create a negative pressure. So it creates a negative pressure of 660 mmHg. So anyway, 650 is near to the 660. It creates a pressure of not 660. Sorry, it creates a pressure of 660 mmHg. And this can be used up to 12 weeks. To remove all the products of conception. So manual vacuum aspiration is a 60 ml syringe. It is a 60 ml syringe to which you attach the Carman's cannula, and you remove all the products of conception. You don't require any anesthesia here. You don't require any electricity. You can do it under mild sedation, and it creates a pressure of 660 mmHg, and it can be used up to 12 weeks. So this is a good question, guys. Alternate to this, we have suction and evacuation. Alternate to manual vacuum aspiration, you have suction and evacuation. Suction and evacuation you will require electricity. Suction and evacuation is also used for removing the products of abortion. So there you will require electricity. Now one more question I would like to ask you people. Now abortion is done up to how many weeks? According to the new MTP Act 2021, abortion can be done up to how many weeks? So now according to the new guidelines, abortion can be done up to 24 weeks. abortion can be done up to 24 weeks. So for rape and incest, or for genetic abnormalities, abortion is done up to 24 weeks. Okay. Previously it was only for up to 20 weeks, but now it is up to 24 weeks. And for contraception failure, abortion is done up to 20 weeks. Okay. Next question. It is severe preeclampsia, right? And severe preeclampsia, यहाँ पे help के सारे features है. Help, hemolysis. Because of the hemolysis, there is increased LDH, elevated liver enzymes. So they have written elevated liver enzymes and low platelet count, right? So this is the help. So hemolysis may you'll have increased, very good Alia, you'll have increased LDH more than 600, absent haptoglobin, elevated liver enzymes, AST and ALT will be more than 70, low platelet count will be less than 1 lakh. Okay, so this is a clear cut HELP syndrome. Next, which type of pelvis is associated with persistent occipito-posterior position? Okay, there are certain single liners which you should know here. सबसे पहले, android pelvis is a triangular pelvis. Android is a triangular pelvis, या male type of pelvis. Anthropoid is anteroposteriorly oval. Gynecoid is circular. Platypelloid is transversely oval. So android is triangular. Anthropoid is anteroposteriorly oval. Gynecoid is circular. Platypelloid is transversely oval. So in which type of pelvis persistent occipito-posterior position is seen? Android pelvis में deep transverse arrest and OP position is seen. Anthropoid pelvis में OP position, face to pubis delivery, and in anthropoid you'll have persistent OP position. Anthropoid favors persistent OP position. Gynecoid is a good pelvis. Platypelloid is a bad pelvis. It is least common. Less than 3% patient only we see the platypelloid pelvis. Platypelloid pelvis favors face presentation. Platypelloid pelvis favors face presentation. Platypelloid favors face presentation. So here the answer is So which type of pelvis favors the persistent OP position? It is the anthropoid pelvis. So anthropoid pelvis favors the persistent OP position. Okay. Next question. An intern is conducting delivery and observes mother developing breathlessness, hypotension, tachycardia, and collapsing. Now, very important sentence here, which we should think of, which gives us the clue of the answer is shock is out of proportion to the bleeding. Shock is out of proportion to the bleeding. What is the most probable cause? In PPH, shock will be in proportion to the bleeding. जितना bleeding हो रहा है उतना shock होगा, right? Amniotic fluid index में you will have breathlessness, hypotension, tachycardia and all, but they won't, like, again there won't be any bleeding in amniotic fluid index. DIC, again DIC also shock should be in proportion to the bleeding. So here whatever the options they have given, no, PPH, uterine inversion, DIC, amniotic fluid index, all these are the causes for postpartum collapse. Postpartum collapse. Now what condition you will have shock out of proportion to bleeding? So shock is out of proportion to the bleeding in uterine inversion. So what is uterine inversion, guys? What is uterine inversion? So uterine inversion is inside out turning of the uterus. Inside out turning of uterus. Now why do we have inside out turning of uterus here? Inside out turning of the uterus here mainly is because of the mismanaged third stage. Most common inside out turning of the uterus is mismanaged third stage. So probably along with the placental delivery, the intern has pulled the uterus. So mismanaged third stage is one of the cause for the uterine inversion. Uterine inversion में why is the shock out of proportion to the bleeding? Uterine inversion में shock is out of proportion to the bleeding because here you have both hemorrhagic shock and due to inside out turning of the uterus. Due to inside out turning of the uterus, you have vagal stimulation also. So you also have vagal shock. You also have vagal shock. So because of both hemorrhagic shock and vagal shock, दोनों के वजह से they'll have shock which is out of proportion to the bleeding. Okay. Right. But the most common cause of death is due to PPH, hemorrhagic shock itself. What is the treatment? What is the treatment? Very good, Mani, correct. Because of the, very good, Muttu. So here, because of the forceful, in Brand's Andrew, ek haath upar, ek haath niche, you're holding the placenta and pulling. But when you don't keep this above hand and you just pull the uterus out, along with the uterus, placenta can come out, right? Yes, Raccoon, I'll speak about that. The last point I'll speak is that only, don't worry. So, stretching of the nerve fibers or the vagal fibers is the reason for the vagal shock. So, management here is, very good, Kalki, the management is manual reposition of the uterus. And the name for this manual reposition of the uterus is Johnson's method. So, we do Johnson's method of manual reposition of the uterus. Johnson's method of manual reposition of the uterus. Johnson's method of manual reposition of the uterus. Okay. So that's about this question. Yes, you also have O'Sullivan's hydrostatic method and all. So now I will take up the queries, guys. Please feel free to put forward your queries. Before we end the session now, I would like to take up the queries. So tell me what are all the queries. First, one query I'm getting here is regarding the how do we manage How do we manage the IuCD with pregnancy in situ? So when you have IuCD with pregnancy in situ, what you should do is remove the IuCD. You can either continue the pregnancy or abort. Continue or abort, it is up to the mother. But if pregnancy, if IuCD is not able to, you are not able to remove the IuCD, threads are not seen. If pregnancy is continued with IuCD in situ, you have the risk of, if pregnancy is continued with IuCD in situ, you have the risk of spontaneous abortion, preterm labor, malformations are less likely, preterm labor, infections. That's all. It's very simple. Okay. Trophoblastic disease itself is a very, very huge topic, but yes, a small brief I can give you. We have gestational trophoblastic disease and gestational trophoblastic neoplasia. Gestational trophoblastic disease is hydatid form mole, where you have partial mole and complete mole. Gestational trophoblastic neoplasia is mainly all the four which I told you, In that, choriocarcinoma is the most common. I'll tell you 4 or 5 single liners, in partial mole, one very important thing, complete mole or partial mole mein, important thing which you have to remember is investigation of choice is USG, where you will see the snowstorm appearance. Okay. And treatment for molar pregnancy is suction and evacuation. So I'm not going in detail into this. I'm just giving you a brief answer. That's all. Okay. And choriocarcinoma, again, it's a very big topic. CTG is again a big topic, guys. I'll try to, make one video and put forward for CTG. Then discussing in 1 minute or 2 minutes, CTG you will not understand at all. So one proper session I'll conduct where I'll explain you entire CTG, how to interpret. On YouTube itself, I'll come live for CTG. Okay? WHO approved emergency contraception is levonorgestrel 1.5 milligrams or 75 micrograms. I-pill. Manual reposition of the uterus is the Johnson's method. So I hope you all enjoyed and learned from this session. And keep studying, guys. Keep studying. So your exams are near. So I keep getting some messages from the students. I'm not able to concentrate. I'm feeling very stressed. I understand that we are very near to the exam at the point where the lot of stress because of the exams. But this is the time where you have to stay strong. Don't give up. Just keep studying. Andar ja raha hai, nahi ja raha hai, yeah, whether I'm doing up to the mark or don't keep those all second thoughts. Keep on studying, keep on preparing. And one very, very important point, guys, don't read anything new. Please don't read anything new. This is a time where you should not at all read anything new. Okay? Revise whatever you have learned. Keep on revising that same again and again. But don't read anything new. Thank you, guys. I'll come up with more videos. You keep messaging me ki what you want. Same way, I'll answer. Rakun, I answered regarding IoCD with pregnancy in situ management, especially for you. Right? Thank you, guys. Thank you so much.